Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the fifth episode of Optometry Series 2.0. I'm very happy to welcome my team member, Ms. Meenakshi. Hi, Meenakshi. Thank you so much for joining. And today's moderator is very special because she is an alumni of the college. I'm very happy to welcome our moderator, Ms. Banu Priya. Hi, Banu Priya, ma'am. Thank you so much for joining with us today.
Thank you, Uda. Thank you for inviting.
Yes. So to know more about Banu Priya ma'am, I welcome the MC for the day, Ms. Priya to share more about the moderator.
Good evening, everyone. I am Priya, a third-year Bachelor of Optometry student at Dr. Agarwal Institute of Optometry. I am very happy to welcome today's moderator, Ms. Priya. Ma'am completed a Bachelor's in Optometry at Agrawal Institute of Optometry and has worked as an executive optometrist at Dr. Agrawal Eye Hospital, Chennai. She has a wide range of expertise in cataract or sharp contact lenses and ortho-optic investigation. She is currently serving as a senior executive optometrist at Dr. Agarwal's Eye Hospital, Hyderabad. We, we are truly honored to have you with us today, ma'am.
Thank
Now
you,
I,
ma'am.
now I would like to welcome today's presenter, Ms. Sowmya, a second-year Bachelor of Optometry student at Dr. Agarwal Institute of Optometry. Ms. Sowmya, please begin your presentation.
Thank you, Priyadashini. So now I'm going to start with my presentation. My topic is about anatomy of lids. Eyelids. The eyelid is a thin, movable fold of skin and muscle that plays a crucial role in ocular protection and maintenance. It serves to shield the eye from environment hazards such as dust, debris, and excessive light. The eyelashes located along the eyelid margin provides an additional barrier by filtering airborne particles and triggering a blink reflex when stimulated. One of the primary physiological functions of the eyelid is to distribute the tear film uniformly across the ocular surface during blinking. This action maintains corneal hydration, removing small irritants and facilitate nutrients exchange. The tear film, composed of lipid, aqueous, and mucin layer, is essential for preserving the transparency and optical quality of the cornea. During sleep, closure of the eyelid prevent exposure keratopathy by minimizing and evaporating tear loss. Additionally, the blink reflects a rapid involuntary closure of the eyelid. Its response to stimuli act as a protective mechanism to guard against potential trauma or foreign bodies. Gross anatomy. Parts of eyelids, canthi, lid margin, palpebral aperture, position of lids. Parts of eyelids. Each eyelid divided by a horizontal furrow, sulcus, separates into an orbital part and a tarsal part. Position of lids. When eye is open, the upper eyelid covers about 1/6 of the cornea and the lower lid just touches the limbus. Canthi. The two lids meet each other at medial and lateral angle or outer the inner canthi. The medial canthus is about 2 mm higher than the lateral canthus. Palpebral aperture. It is the elliptical space between upper and the lower lid. When the eye are open, it measures about 10 to 11 mm vertically in the center and about 28 to 30 mm horizontally. Lid margin. It is about 2 mm broad and it is divided into two parts by punctum. The medial lacrimal portion is rounded and divided by lashes or gland. The lateral ciliary portion consists of rounded anterior border, a sharp posterior border, and an intermarginal strip. Layers of the eyelid. From superficial to deep, the eyelids has 7 layers. Skin, subcutaneous areolar tissue, orbicularis oculi muscle, submuscular areolar tissue, fibrous layer, tarsal plate, and orbital septum, levator palpebrae superioris and molar muscle, upper lid only, conjunctiva. Structure. Skin. Thinnest skin of the body, no fat underneath, has fine hair, sweat glands, and sebaceous gland. Possesses numerous folds, especially in the upper eyelid, palpebral furrow. The subcutaneous areolar tissue. It is very loose and contain no fat. It is thus readily distended edema or blood. The layers of striated muscle. It consists of orbicularis oculi, which forms an oval sheet across the eyelid, striated voluntary muscle. It is supplied by zygomatic branches of the facial nerve, arranged in concentric ring around the palpebral fissure, responsible for closing the eyelid, divided into three parts: the orbital, the palpebral, the lacrimal. Orbital part. Overlap the orbital margin, response for forceful closure, that is squinting. Preseptal part lies over the orbital septum, response for involuntary blinking. Pretarsal part overlies the tarsal plate, responsible for involuntary blinking and gentle closure. The pretarsal and preseptal part attaches medially to the medial palpebral ligament and laterally to the lateral palpebral raphe. In addition, the upper lid also contains levator palpebrae superioris muscle. It arises from apex of the orbit and it is inserted by three parts on the skin of lid, anterior surface of tarsal plate and conjunctiva of superior fornix. It rises the upper lid and it is supplied by a branches of oculomotor nerve. Submuscular areolar tissue. Submuscular areolar tissue, the layer of loose connective tissue. The nerve and the vessel lies in this layer. Therefore, to anesthetize lid, injection is given in this place. Fibrous layer. Provide the main support to the eyelid. Consists of tarsal plate, tarsus, dense fibrous tissue, orbital septum, thin fibrous membrane. Tarsal plate. Dense connective tissue plate gives the eyelid its shape and firmness. Upper superior tarsal plate, 29 mm long, 10 mm high at center. Lower inferior tarsal plate, 29 mm long, 4 mm high at center. The lower and upper tarsal join with each other at medial and lateral canthi and are attached to the orbital margin through medial and lateral palpebrae ligaments. Contain vertical rows of modified sebaceous gland, meibomian gland, and tarsal gland. Orbital septum. A thin fibrous membrane extending from the orbit rim to the tarsal plate act as a barrier, preventing orbital fat from prolapsing forward into the eyelid. Also act as a barrier to infection spread from eyelid to the orbit. In the upper eyelid, it is precised by the levator aponeurosis. Levator palpebrae superioris. Striated muscle originating from the lesser wings of the sphenoid bone passes anteriorly above the superior rectus muscle, innervated by a oculomotor nerve, that is third cranial nerve, divided into aponeurosis, anterior fibrous expansion, Muller muscle, superior tarsal muscle, post smooth muscle. Levator aponeurosis. Fan-shaped fibrous expansion of the levator muscle inserted into the anterior surface of the superior tarsal plate and the skin, forming the upper lid crease. Primary elevator of the upper eyelid. Muller muscle. Smooth muscle originating from the under surface of the levator, inserting into the superior border of the superior tarsal plate, innervated by a sympathetic nervous system, provide 1 to 2 mm of upper lid elevation. Damage to sympathetic supply, Horner's syndrome, cause ptosis, drooping of eyelid. Conjunctiva. A thin transparent mucous layer membrane. It lines the inner surface of the eyelid, palpebral conjunctiva, reflects at the fornix to cover the anterior surface of the eyeball, bulbar conjunctiva, rich in goblet cells that produce mucin, inner layer of tear film, contain accessory lacrimal gland, cross and wolfring. Glands of eyelids. Meibomian gland. A thin transparent mucous membrane lines the inner surface of the eyelid, palpebral conjunctiva, reflects all the fornix to cover the anterior surface of the eyeball, bulbar conjunctiva, rich in goblet cells that produce mucin, inner layer of tear film, contain accessory lacrimal gland, cross and wolfring. Glands of Zeiss. These are also sebaceous gland which open into the follicle of eyelashes. Accessory lacrimal gland of Wolfram. These are present near the upper border of tarsal plate. Glands of mole, modified sweat glands situated near the hair follicles or into the ducts of Zeiss gland. They do not open directly into the skin surface as elsewhere. Blood supply. Arteries. In human, the eyelids are supplied with blood by two arteries on each upper and lower eyelid. The arteries are formed by anastomosis of the lateral palpebral arteries and medial palpebral arteries branching off from the lacrimal artery and ophthalmic artery respectively. Venous drainage. Superficial veins drain into facial nerve and superficial temporal vein. Deep veins drain into the ophthalmic vein, which empty into the cavernous sinus. Lymphatic drainage. Lymphatics arranged as post-tarsal and pre-tarsal. Those from lateral off of the lids drain into preauricular lymph node, and those from the medial off of the eyelid drain into submandibular lymph node. Nerve supply. Motor supply. Orbicularis oculi, facial nerve, 7th cranial nerve, levator palpebrae superioris, oculomotor nerve, 3rd cranial nerve, muller muscle, sympathetic fibers. Sensory supply. Upper eyelid. Ophthalmic division of the trigeminal nerve V1 via the lacrimal, supraorbital, supratrochlear and infratrochlear nerve. Lower eyelid. Maxillary division of the trigeminal nerve V2 via the infraorbital nerve. Physiology of eyelid movement. Function. Protecting of the eye from foreign body, dust and injury. Spreading the tear film uniformly over the corneal surface. Keeping the cornea moist, essential for its transparency and health. Regulating light entry into the eye, example during bright light. Preventing the eye from drying out during sleep. Eyelid opening mechanism. Primary muscle. Levator palpebrae superioris, striated voluntary muscle, innervated by oculomotor nerve, that is 3rd cranial nerve. Action. Contraction pulls the superior tarsal plate and lid skin upward and backward, responsible for main eyelid elevation and creates the upper eyelid crease. Second muscle, muller muscle, superior tarsal muscle, smooth involuntary muscle, innervated by sympathetic nervous system. Action. Provides an additional 1 to 2 mm of lid elevation, maintains wide eye opening, example in alertness. Loss of function leads to mild ptosis, Horner syndrome. Indirect influence. Fortalis muscle, forehead muscle can raise eyebrow indirectly, lifting the lids. Eyelid closing mechanism. Primary muscle, orbicularis oculi muscle, striated voluntary muscle, innervated by facial nerve, 7th cranial nerve. Action, contraction pull eyelid together, 3 parts and their function. Pre-tarsal and pre-septal part, responsible for involuntary blinking, spontaneous and reflex, crucial for lacrimal pump mechanism, aids tear drainage. Orbital part, responsible for forceful closure, squinting, winking, provide a tight seal. Types of blinking. Spontaneous blink occurs regularly 10 to 15 blinks per minute without conscious effort. Function, distribute tear film, clear debris, maintain corneal moisture. Voluntary blinks, conscious effort to close eyelid. Example, winking. Involves coordinating action of palpebral and orbital part of orbicularis. Reflect blink. Rapid involuntary closure in response to stimuli. Example, corneal reflex touches the cornea. Dazzle reflex, sudden bright light. Threat reflex, object rapidly approaching eye. Auditory reflex, sound noise. Lacrimal pump mechanism. Mechanism operates with blinking movement of the eyelid. Muscle involved. Fibers of the pretarsal and preseptal portion of the orbicularis oculi originating from the lacrimal fascica and posterior lacrimal crest. Process during blinking. Contraction. Orbicularis oculi contracts. Compression the puncta and canaliculi. Sac expansion. At the same time, the lacrimal sac expand, creating negative pressure. Tear draw. Tear drawn into the canaliculi and then into the lacrimal sac. Relaxation. When the orbicularis oculi relax, the sac collapses, pushing tear down into the nasolacrimal duct. Important. Importance: efficiently drains tear from the eye surface into the nasal cavity. Coordination. During blinking, LPS levator palpebrae superioris relaxes while orbicularis oculi contract. Bell's phenomenon. Definition: on attempt eyelid closure, the eyeball rolls upward and downward. Protective role: safeguard the cornea by tucking it under the upper lid, especially if eyelid closure is incomplete. Example: facial nerve palsy. Clinical relevance: important sign to access in patient with facial paralysis. Inverse Bell's phenomenon: abnormal rotation of globe downward and outward on closure. Blepharospasm. Blepharospasm. Involuntary eyelid closure. Sustained forceful involuntary eyelid closure. Muscle involved: orbicularis oculi and eyebrow muscle. Types: tonic. Lid locked shut. Clonic: rapid lid fluttering. Causes: essential, idiopathic, no clear cause, often 45 to 65 years. Reflex: triggered by sensory irritation. Example: corneal issue, bright light, facial nerve stimulation. Impact: can cause persistent tearing, lid swelling, and severe visual disability. Treatment: botulinum toxin, Botex, facial denervation, severe cases, or treating underlying cause for reflex type. Eyelid disorders. Inflammatory and infectious condition. Chalazion, chronic painless lymph due to blocked meibomian gland. Hordeolum, it is also known as stay. Acute painful infection of eyelid gland. Blepharitis, chronic inflammation of eyelid margin. Molluscum contagiosum, viral lesion caused by pox virus. Malposition of lids. Entropion, inward turning of eyelid margin. Ectropion, outward turning of eyelid margin. Benign and malignant tumor. Dermatochalasis, loose, sagging eyelid skin. Xanthelasma, yellowish plaque near inner eyelid. Cholesterol deposit. Basal cell carcinoma, most common malignant eyelid tumor. Sebaceous gland carcinoma, aggressive eyelid malignancy. Hemangioma, benign vascular tumor, common in infant. Ptosis, drooping of upper eyelid. Functions abnormalities. Trichiasm. Trichiasis, misdirected eyelashes rubbing the cornea. Lack of thalamus, inability to fully closed eyelid. These are my reference. Thank you.
Thank you so much, Sowmya. It was actually a very elaborate presentation on anatomy of eyelids. And kudos to your effort in making the presentation just after completing your first year. It was very nice and elaborate presentation, Sowmya.
Thank you.
And now I request the moderator, Banu Priya ma'am, to add your valuable inputs, ma'am.
So we'll go with the conjunctivitis first. Can you go to fourth slide? So ocular surface is nothing but the combination of both cornea and the conjunctiva. Vision depends upon the maintenance of this ocular surface. So we'll go to the conjunctivitis. So conjunctivitis is nothing but red eye. So we need to understand the differentiation between the hyperemia and conjunctivitis first. This is not mentioned in the figure in the textbook. So normal hyperemia is nothing but the vessel dilation. So we'll see the redness, but no underlying infection or inflammation will be there. This could be due to some FB fallen into our eye. So this is different from our conjunctivitis. This is something, conjunctivitis is something which is caused by an causative organism. So it could be viral, bacterial, allergic, or chemical. So the most common viral sources, adenovirus and herpes zoster, herpes simplex virus. So the bacterial origin would be Staphylococcus pneumoniae aureus, and allergic conjunctivitis could be due to pollen, perfume, dust and smoke. And the signs and symptoms. The signs and symptoms would be redness, itching, watering, discharge, and pain. So the final treatment would be lubricating drops, antibiotic drops, warm compression will soothe the pain, and antibiotic eye drops are prescribed in case of viral and bacterial conjunctivitis. And in case of allergic conjunctivitis, steroidal drops are advised and with proper review. So the drops has to be tapered, and then after that, the subsiding of the conjunctivitis, antihistamine eye drops are prescribed. And most importantly, patient should be instructed to avoid rubbing of eyes. This will also cause keratoconus in the cornea. Okay? So if a patient is coming to the clinic with red eyes, we need to take a detailed history regarding it. So if the conjunctivitis is associated with pain, it could be because of keratitis, angular glaucoma, anterior. So these are all conditions indicated with presence of blurring of vision and photophobia with pain. Okay. In case if it is of a painless red eyes, it could be because of regular conjunctivitis, or anterior uveitis can also be involved, but which will cause a blurring of vision. In normal conjunctivitis, vision is not disturbed. And if a patient is coming with conjunctivitis, this same conjunctivitis is seen in anterior uveitis and glaucoma, angular glaucoma also. How to differentiate this? So these are the common things which can be seen to compare and differential diagnosis differently. So the vision in conjunctivitis, vision will go to the next slide. So vision is not disturbed in conjunctivitis and anterior uveitis, but it is disturbed in angular glaucoma due to corneal edema. And in pain, this will be mild to moderate in conjunctivitis and uveitis, but it will be more in angular glaucoma. Discharge. Discharge could be mucopurulent or watery in conjunctivitis. In other two cases, it will be mostly watery. And photophobia will be absent in conjunctivitis, where other two cases will present photophobia. So colored halos also will not be there, but in other two cases it would be there. And condition, we need to see the type of condition present in the red eyes. If it is superficial, it is indicative of conjunctivitis, and deep ciliary condition could be present in uveitis, and in glaucoma also you will be having deep ciliary condition. Pupil is not involved in conjunctivitis, whereas the other two cases, pupil are involved. Both are in both cases, it will be sluggishly reacting. Okay, and then ACD. ACD will be normal in both anterior and anterior uveitis and conjunctivitis, but it would be shallow in angular glaucoma. Then comes your tenderness. Tenderness won't be there in conjunctivitis. In other two cases, it will be there. And IOP will be so normal in conjunctivitis in other two cases, and in uveitis it could be normal or raised, but in angular glaucoma it is always raised. Right? So these are the common three types of conjunctivitis which are regularly seen in our clinic. So allergic conjunctivitis. Allergic itching is the hallmark sign in case of allergic conjunctivitis, and it could be caused because of hay fever, allergic rhinitis, atopic dermatitis, asthma. So it will have kind of mild pain, and papillae will be seen in allergic conjunctivitis. Where in bacterial conjunctivitis, mucopurulent discharge is the hallmark sign. So if a patient is coming with red eye, with mucopurulent, yellowish, greenish discharge is there, it could be an indicator of bacterial conjunctivitis. So here also papillae will be seen, pain would be there, mild to moderate pain would be there. And chemosis will not be seen in bacterial conjunctivitis, but it is seen in allergic conjunctivitis. Then comes your viral conjunctivitis. This is always associated with mostly associated with upper respiratory tract infection, cold, cough, something like that. So, watery discharge will be there. Sometimes, in case of it is affected because of herpes zoster ophthalmicus, in that case, mucopurulent discharge is seen. So, this is how we need to differentiate between the red eye. It could the other between the red. Next slide. So here we'll see a small anatomy. So as we know, the third nerve will be we have a saying in our college, all three SO4 elastic. All the other muscles except lateral rectus, which is supplied by fourth nerve, trochlear nerve, and elastic SO4, superior oblique muscle is supplied by sixth nerve. So other than this, is supplied by third nerve. Okay, this have been presented before by Sowmya. So these are the other functions and innovations of the ocular muscle. So next slide. So ptosis. Ptosis is nothing but drooping of the eyelid. So it could be because of various reasons. Neurogenic because of the levator muscle disinnervation, and myogenic levator muscle myopathy. It could be mechanical because of the lesion present over the lid. Aponeurotic is something like aging. Traumatic ptosis will also be there. Congenital means here can you see the upper image? There is no lid crease seen here in the upper image, but in the lower image, lid crease is seen. So these are the things which differentiate from the congenital and acquired one. Symptoms are droopy eyelids, and in case of pupil coverage, you'll be having defective vision and could cause diplopia also. And in myasthenia gravis cases, diurnal variability will be seen. So the ptosis will not be same all during the day. It will be different in different times. So in case of ptosis evaluation, we'll be checking if we'll check the function of the levator muscle. So for this, we'll be keeping our examiner will be keeping our thumb over the patient's eyebrow, and we'll ask the patient to look down. We'll mark the position of the upper lid. So we'll ask the patient to look up directly. So the distance the lid has traveled from lower gaze to upper gaze is measured. So normal range is 9 to 15 mm. Fair, the distance if it is 5 to 9 mm, it is also fair, but less than 4 mm is indicative of ptosis. Then PFH, palpebral fissure height. Normal palpebral fissure height is 7 to 10 mm. But in case of ptosis, we need to compare. In case of specifically unilateral ptosis, we'll be comparing the PFH. If the difference is less than 1 or 2 mm, it is okay. So 3 to 4 moderate ptosis is present, and in case of less than more than 4 mm difference is severe ptosis. And MCD, marginal crease distance is also measured. So normal crease distance would be 7 to 8 mm. More than 10 mm is seen in involutional ptosis. So treatment would be levator reception and frontalis growth substance. Next slide. So ptosis in different conditions. So in third nerve palsy, it is presented with complete or partial ptosis with mydriasis, also sometimes face pupil, down and out. This is the can you see the first image there? Down and out of the eye position is seen. And in case of Horner syndrome, partial ptosis will be there, meiosis will be there, and with inclusive of facial anhidrosis. Dryness of the face is also seen. And in Marcus-Gunn-Jaunkin syndrome, partial ptosis is seen. Go back, in Marcus-Gunn-Jaunkin syndrome, with upper jaw, lower jaw movement, ptosis will be seen. So this is something congenital. And in myasthenia gravis, partial ptosis with spaced pupil. And in myasthenia gravis, we'll be doing one more test called ice pack test. In ice pack test, what we'll be doing? We'll place ice pack over the closed lid, and we'll be placing the ice pack for 1 minute. So before and after, palpebral fissure height is measured. So if there is an improvement in ptosis, that means if the lesser palpebral fissure has improved after the test, which is this is an indicator of myasthenia gravis. And in the chronic progressive external ophthalmoplegia, you will be seeing bilateral ptosis with restricted ocular movement. So this is how you need to differentiate ptosis in different conditions. So according to this, the treatment, everything goes. Trichiasis is nothing but misdirection of the lid. So this could be because of the secondary inflammation, glaucoma, Stevens-Johnson syndrome, chemical bonds, or ulcerative blepharitis. So symptoms are acne sensation, irritation, inability to open the eyes, inability to open the eyes, and watering. So signs could be misdirected eyelashes, conjunctival conditions, corneal erosion, opacity, and corneal scar. This would be the final stage. So because of the constant rubbing of the trichiatic latch, the cornea is getting damaged. So in this case, the photophobia may also be there. So treatment. Non-surgical treatment is epilation. So surgical treatment would be intermarginal split lamella with graft, posterior lamella, tarsal rotation can be done. Blepharitis. Blepharitis is nothing but your inflammation of the eyelid. So this could be bacterial or seborrheic blepharitis is nothing but which is associated with skin disorder, dandruff like this. It can also be caused due to gland dysfunction, eyelid gland dysfunction. And in case of parasitic infection, this is because of the pubic lice which is seen over the lid margin. Signs and symptoms would be grittiness, itching, watering, redness, puffing of lips, swelling of lips. Everything could be included. So the treatment would be lid hygiene. So it has to be cleaned properly. Basically, we'll be using diluted baby shampoo with the diluted baby shampoo and clean the eyelid with the use of butter. So, and then warm compression will be given. Antibiotic eye drops and lubricants are usually given. And in case of recurrent blepharitis, in the non-resolving cases, we will be prescribing steroidal eye drops. In case of seborrheic blepharitis, associated skin disorder has to be treated. Chalazion. Chalazion is nothing but lesion on the benign lesion on the eyelid. So this is caused by a blocked sebaceous gland. This is not an infection. So chalazion, the blocked Zeiss gland will cause superficial inflammation along the lid margin. So which can be seen in the top image. This could be because of the blocked Zeiss gland. So lid margins are involved. This is because the Zeiss glands are present near the lid margin. So again, blocked meibomian gland causes deeper inflammation, which is seen in the which is away from the lid margin. So signs and symptoms will be slowly enlarging. This is a chronic condition, slowly enlarging, non-tender, benign lesion. Recurrent lesion should be evaluated for malignancy. Upper lid chalazions induces corneal astigmatism, corneal aberrations, and causes blurring. The treatment would be lid hygiene again, warm compression. Antibiotics are advised if only there is an infection evidence. So mostly resolves with conservative management, above management in a month. And in persistent cases, incision and curettage is possible. So complications would be untreated lesions may predispose to preseptal cellulitis. Hordeolum. Hordeolum is nothing but a style. Infection is caused because of the infection of the gland. Previously we saw blocked gland. So here it is infected gland. So this will have pain. Okay? And the acute bacterial infection of the sebaceous glands of eyelid, which is nothing but your meibomian glands and glands of Zeiss. So glands of Zeiss, if it is affected, it causes external hordeolum, and in case of meibomian glands infection, it causes internal hordeolum. So signs and symptoms would be erythema, redness of the lid, swelling of the eyelid, redness, conjunctival redness, tenderness, watering, and mechanical tone. Treatment would be eyelid hygiene, warm compression, antibiotic eye drops with lubricating drops for soothing effect, IC. Incision and curettage will be done at the last. Complications would be preseptal cellulitis, orbital cellulitis, keratitis, and corneal aberration. This could also be there in case of persistent chronic infection. Scarring and deformities of lips could also be xanthelasma palpabrum. This is some cholesterol deposits seen over the lid in near the lateral and medial campuses. These are benign lesions which has no harm to do with your eyes. So, in case of cosmetic concern is there, then laser treatment can be undergone. Otherwise, no treatment is needed. These are benign, harmless lesions. Ectopia. Entropion. Entropion is the inward turning of the lower eyelid. So this could be because of the horizontal loosening of the eyelid muscle. So improper function of the eyelid retractors, overriding of the orbicularis oculi could be also a reason. Acute spastic entropion caused because of a lid infection, underlying lid infection. So the signs and symptoms would be redness, irritation, pain, photophobia, epiphora, watering, decreased vision in case of cornea is involved. Okay, go back on. So treatment differs with etiology. So primary treatment comprises with prescribing artificial tears and the bandage contact lenses. Because of the orbicular oculi muscle is involved, botulinum injection will be given in case of overriding orbicular oculi muscle. So and a lateral tarsal strip operation when resection is done to correct this, and repair of lower eyelid retractors can be done to stabilize the inferior border of the tarsal. So here is the differential diagnostic picture. So first picture is trichiasis, misdirected eyelid. Madarosis is the second picture. So here the loss of eyelashes will be seen. Symblepharon. Symblepharon is nothing but the eyelid attachment to the bulbar conjunctiva. So, and in foliosis, the discoloration of the lashes is seen, and in trachoma, it is a leading cause of blindness. So, one of the leading cause of blindness is caused by chlamydial trachomatis bacterial infection. It starts with normal blepharitis and conjunctivitis and leads to corneal ulceration. So pemphigoid is also an autoimmune disease which involves the mucous membrane, that is conjunctiva of the eyelid. With this will also sort as in blepharitis. It will lead to scarring and ulceration of the cornea. And next comes your ectropion. This is because of the outward turning of the eyelid. So this could be because of disinnervation of the lower lid retractor, orbicularis oculi, and in case of seventh nerve palsy, this ectropion will be seen. Mechanical ectropion is due to the edema of the lower lid. So signs and symptoms are redness, epiphora, dryness, effervescence. And in severe conditions are developed with punctal epithelial erosion, ulceration, which is exposed keratopathy, and permanent vision loss. Treatment depends on the severity. So if the cornea is involved, that time surgical treatment has to be considered. In the other case, the lubricants and ointment is very important. Lag of thermal. Lag of thermal is incomplete closure of the eyelid. So this is because of your this could be because of Bell's palsy, and in enophthalmos and exophthalmos, and underlying infection, so trauma, tumor, and in sleep also you'll be having lag of thermal because this is called as nocturnal lag of thermal. So systemic associations could also be there: diabetes, hypertension, and vitamin A deficiency, hypothyroidism. Also can cause lag of thyroid. The signs and symptoms are FD sensitivity, epiphora, watering, pain with increased corneal exposure and dryness, which will lead to functionally exposure keratopathy. Treatment is eye drops, lubricants, antibiotics, and ointments. The treatment would be target therapy, gold weight implantation, levator recession. loosening the LPS muscle, lower lid tightening and elevation. Yeah, I think I'm with my
Thank you so much, ma'am. It was a very nice and elaborative clinical pearls for the content to take home from the presentation what Sowmya made to the presentation you made. You had covered everything from the infection stage to the tumors and the ocular injuries that creates complication in the eyelids. Thank you so much for an elaborative explanation on clinical pearls, ma'am.
thank you.
And from the student's perspective, there are one question that is related to the ocular conditions, ma'am. I'll read out for you. In case of infections, the primary thing is to check the vision and treat them and send them off. What could be the follow-up management that is done for the infection part of eyelids, ma'am?
So as I said, it depends upon the etiology. So few infections will not go for long. So with the antibiotic fixes, they will be reduced. After the inflammation or infection has calmed down, then you can go for the spectacle correction. So in the infectious stage, we are not supposed to do any power correction.
Thank you so
Was
much,
that
ma'am.
clear?
Yeah. It's clear. Over to Gomati now.
Thank you so much, Meenakshi. Thank you so much, Banu Priya ma'am, for joining with us as the moderator for the day. So from Hyderabad, whenever possible, please come to Chennai. Don't forget to join us in the college. We'd like to host you on another wonderful platform. Especially looking forward to have you as an active member of the Alumni Association, ma'am.
Sure.
Thank you so much, ma'am. Dear audience, thank you all for your continuous support towards Optometry series. If you like this video, give a thumbs up and share with all your friends. The announcement for this particular week, admissions are open for bachelor's, master's, and fellowship in Optometry at Dr. Agarwal's Institute of Optometry. All the details regarding the admission is given in the description box. And another exciting announcement for this particular week is we are collaborating with the Loyola ICAM College for the new conference ISVTech. Abstracts are invited until June 30th and the registrations are also open. Please do enroll it and don't forget to be the part of the future of eye care. See you all in the next video. Thank you all so much.